Good evening, everyone. Thank you very much for joining our fourth Health Security Dialogue, hosted by Global Health Policy Innovation Policy Program, GHIPP, at GRIPS. My name is Hiromi Murakami, and I'm with GHIPP, and I'll be facilitating this dialogue series. We are very honored to welcome a distinguished guest today from Geneva, and Dr. Osamu Kunii of the Global Fund in this very important timing. The Japanese government, as you well know, that had just declared a state of emergency last week for a second time, and we continue to face unforeseeable future. And the purpose of this dialogue series is to build a community where we can share knowledge, experience, and to discuss how to best prepare for the future crisis and build a health resilience. In the past week, we have seen some nations have started vaccinations, but still majority of nations in the world are still struggling with the situation, including Japan. And there is a multilateral framework, which is called COVAX facility, is in place to provide vaccines for lower and the lower income, middle income countries. And we'd like to hear more about how international community can deal with this pandemic. And Dr. Kunii will be sharing his view regarding global solidarity to end COVID-19 pandemic, progress and challenges. We have a dialogue and Q&A following the Dr. Kunii's talk, and also Dr. Kurokawa will be sharing his view afterwards. For administrative announcement, if you have any questions, please submit your questions in the Q&A column on the bottom of your screen so that we can, facilitator or the speakers can pick up your questions during the discussion. And let me introduce today's speaker, Dr. Osamu Kunii. He is the head of strategy, investment, and impact division of the Global Fund to fight AIDS, tuberculosis, and malaria. He is managing 5 departments, namely strategic information, technical advice and partnership, health, finance, and community, rights and gender, and access to funding. He has over 25 years of experience in global health, especially maternal and child health, infectious disease control, health systems, health policy, and diplomacy by serving in various posts, such as Deputy Director of Aid Planning Division in the Japan Ministry of Foreign Affairs, Professor of Global Health at Nagasaki University Research Institute of Tropical Medicine, Senior Advisor at UNICEF Headquarters, Chief of Health and Child Survival Program in UNICEF Myanmar and Somalia. And we have Dr. Kiyoshi Kurokawa from GRIPS as a commentator, and he is a professor emeritus directing GHIPP, as he has long been involved in this global health arena, has substantial knowledge about this realm. He is a member of World Dementia Council, International Scientific Advisory Committee, and many other academic institutions. With that, I'd like to pass the microphone to Dr. Kunii, and we very much appreciate that you are sharing your views with us. Thank you very much, and all yours.
Thank you very much, Ms. Murakami-san, and also Dr. Kurokawa sensei. Okay, so today I now, can you see my screen and also at the first page of slide, right? Okay, that's great. Okay, so good evening, good afternoon, good morning, everyone. I'm very much pleased to be here and give a kind of lecture webinar. And today I'm going to talk about this global solidarity to end the COVID-19 pandemic. It is full screen. Can you see in the full screen? Okay, great. And now second screen, could you see or not? Okay, good. So I'm talking about global situation of COVID-19 pandemic and global response, its progress and challenge, and toward ending epidemics. Okay, so So now, as you know, that new cases and deaths are increasing. Some of the countries exponentially. Okay, maybe some of the countries are really kind of facing second wave or third wave, and yeah, actually, this daily death by regions quite large in Europe. Europe is now facing second or third wave. Kind of, the most of the countries in Europe are really kind of suffering from those, the many cases and death. And still, US and North America has a lot of cases and death, and even Latin America. And Asia, especially southern continent of Asia, also are suffering from death and the cases of COVID. So Japan, as all of you know, that also facing very big wave, and state of emergency are now issued, and you are, who are living in Japan every day, you are really kind of suffering from a lot of bottlenecks of this one. And currently, I'm now living in Switzerland, Geneva, and even this Switzerland has less than one tenth of Japanese population. This total cases are almost much higher than Japan, and total deaths also kind of double. And we have, even first wave, you can see in March or April, we really kind of, suffering from a daily increase, almost exponential, the increase of cases. And that we locked down, and we closed our office, and started our the homework. But now this second wave or third wave we call is a much higher than this first wave. You can see, this first wave is very small, but as I said, it was a really kind of big suffering. But now this second wave is really, huge. So most of the hospitals in Geneva full of patients, so they have no capacity to accept the new cases or new patients. So they are transferring the patients to other canton, other places. And France, adjacent to Switzerland, also really kind of suffering. Now kind of subsided, but still quite a lot of cases. It is a sixth in terms of the total number of cases. US, it is a first. As you know, US has a CDC, Center for Disease Control and Prevention. So, and also USA ranked first as a country prepared for pandemic, according to the Johns Hopkins and other Global Health Security Index in the past. It is a report in 2019. But finally, this became the kind of a worst, in terms of this COVID pandemic. 23 million, cases, and total deaths is almost 400,000 cases. The death. UK, it is fifth. As you know, the variant is predominant now in UK, and total deaths. Even first wave, they had a huge, the toll of death. But the second wave, they also couldn't, prevent. So the Prime Minister Boris Johnson said, now this pandemic and epidemic is out of control. It's so difficult for them, even using lockdown. Germany, as country of success in a first wave, but now you can see here, so huge wave, almost exponential, especially in terms of death. Actually, the Germany could, suppress, minimize, I can say, minimize that death compared to other European countries in a first wave. But second wave, it is very, very difficult to suppress. For example, this is Germany's lockdown rule. So private meetings limit just only one person from other household. And parents could get extra 10 days leave to look after children, and single parents could get 20 days for looking after children. And residents in areas with more than 200 cases per 100,000 can be restricted from travelers more than 15 kilometers. And also set a quarantine arriving in Germany from high risk areas, submit 2 negative test results within 5 days, quarantine between tests. So, each country are kind of providing specific measures and the stricter lockdown and trying to suppress this, the huge wave of second or third wave of epidemic. If you look at the middle or low income countries, also really kind of suffering from this the epidemics. Actually, India, it is not wave because big wave already hitting India, and it is incredible because of daily case become 100K just in a single country. Could you imagine? And even death, almost 10,000 death every day. So it is kind of a huge, that event in this India. And South Africa, it is, even Africa also gets this epidemics. And South Africa is now the second wave, and still exponential increase is happening. Zambia, you can see it is also real big increase in a second wave. Tanzania, this is a country with population almost half of Japan, around 58 million, and the land is 1.5 times larger than Japan. And you can see this is only 509 cases. So can you see this is a country of success? No, actually president stopped reporting the cases of COVID. Can you imagine that, the president decided we shouldn't count this, COVID because it gives, so much threat. And there's no cases in COVID here in this Tanzania. So many of my friends are working inside of the Tanzania, and they said to me that even, the meeting for COVID, that person, he's, the expatriate, and he wear mask, but minister mentioned that there's no COVID, so there's no need to be afraid of this COVID. So, they have to, take off the masks for the meeting. Maybe it's a quite, COVID is also rampant in this Tanzania, but there is no way to measure. There are many, African countries and other low-income countries which are kind of lack of laboratory and testing. So still, we do not know which countries are really kind of under big waves and which waves of the epidemic. So even reported cases, we could see the second big wave of the COVID epidemic in Africa, but maybe the real situation of these numbers could be several times, as many as reported cases. So now that the annual death, that the COVID-19's the daily death is almost 15,000. And now the total annual death of COVID-19 is the first and top cause of death among infectious diseases. Actually, in the past, the TB, tuberculosis, was a top cause of death among pathogens, but now the COVID-19 exceeding. But still, this instance or cases, of course, reported cases are maybe underestimated, because there are a lot of unreported cases. But still, malaria is much more. Malaria has more than 200 million cases per year. And if you look at the latent tuberculosis, it is 1.7 billion. Of course, latent TB is no symptomatic, but later it could show that the symptom. So still, lots of pathogens are around. As you know, we have more than 1,000 pathogens, for humans, and still, there are a lot of kind of emerging diseases as an infection. But the COVID-19 is one of those pathogens. But of course, that it is really kind of dreadful. And some of the countries, antibody positivity, it's very much increased. This is case of Manaus. Currently, over 70% of the populations are COVID-19 antibody positive, meaning maybe natural herd immunity could be quite difficult to be set up. So yeah, let's see. But there are some of the places already, this antibody is over 50% of the population. This is a case of the Manaus extending the graveyard because daily so many deaths are added, so they needed to extend their graveyard. This picture really kind of reminded me of the days of HIV in Africa, 1980s, 90s. At that time, they didn't know they are those deaths, the exponentially happening are by HIV, because initially they called us slim diseases without knowing or diagnosing many, the people, especially at the reproductive ages, are dying. So if you look at the life expectancy, the HIV really kind of impacted the rapid drop of life expectancy, and some of the countries lost the lifespan more than 10 years. Actually, this time the COVID influenced this drop of life expectancy just around 1 or 2 years. Even Brazil, it is a 1 year. Meaning, because as you know, if you look at the premature death, maybe COVID is not so much influencing, because COVID really hit the people in the elderly, among elderly. So usually the loss of expectancy could be maybe minimized. But anyway, and if you look at the fatality and infectivity in terms of basic reproduction numbers, and also infection fatality risks, actually there are many other pathogens much severe in terms of fatality and the infectivity. For example, HIV was said that the mortality is almost over 95%, and the measles it has a very, very high infectivity. When I look at one case of measles in a refugee camp in Africa and others, I was so scared, because it spread very, very rapidly and increased at the mortality, especially under 5. But why is this COVID-19 is such a threat? Because they said this is a master of deceiving, or hit and run killers. Because this spread, this virus is spreading even without the symptoms. So it's sneaking in the medical facilities and the elderly facilities. So it's really kind of sneaking and deceiving the people, and underestimate severity. And many premiers, president, and the prime ministers also said, okay, this is just flu, because even young stars even get infected, not so serious. So while people are underestimating this severity, it's really kind of spreading. But it also shows that the rapid change of the stage clinical features into a serious stages. So they show that the very, very unique clinical features of sensitivity, blood clotting, and overdriving that the immune system. So the clinicians told me that it's a really kind of never experienced in such very rapid and sudden change of the situation, clinical symptoms, and it's really kind of severe and very, very difficult to treat, they said. But of course, that the COVID also impact directly or indirectly other areas like economy. As you know, that already countries spent more than 18 trillion US dollar for COVID measures of COVID, but will lose another, the 12 trillion by the end of 2021. So even compared to the Lehman shock uh, and great the loss of this economic recession, this year and last year and this year would be seen as a really, big drop in terms of GDP and the growth of the economy. And of course, this COVID or indirect, impact by COVID, meaning especially lockdown, give a big, impact on poverty, education, gender issues, and others. For example, push 150 million people to extreme poverty and 135 million to severe hunger and starvations. That is why WFP is also working very hard to reach out to those who are suffering from the starvation and hunger. And because of the school closures, 1.5 billion children are affected in 160 countries. This would, of course, give short-term, but at the same time, long-term effect on child growth and kind of mentality as well. And this COVID pandemic is also called shadow pandemic of gender violence or intimate partners violence. And some of the countries observe some girls and the women missing, maybe because of domestic violence and others. And this COVID really broadened the inequity. So you can see some of the ethnic groups or migrants in Europe and other, even US, also had the inequitable, the result of COVID in terms of infectivity and also mortality as well. This equity is very, very critical. So in my organization, Global Fund, we also support this inequity by making data, disaggregated data available. We have 6 dimensions of inequity: ethnicity, income, location, education, gender, and ages. So we really need to generate that disaggregated data for this equity, so that we could reach out to the people who are really suffering from this the COVID pandemic. This is kind of example. That's a gender inequity, that 70% of the health and the social care workforce are female. So they are more kind of likely to get infected with HIV. That's COVID. And, lockdown, many countries really impose this lockdown. And this lockdown really disrupted the lots of health programs, even immunizations and HIV, ART provision, detection and treatment of tuberculosis, and the bednet campaigns, etc. So this lockdown really decreased the TB case notification, diagnosis, and also a treatment. And WHO, UNAIDS, and other technical partners made kind of modeling of this disruption by lockdown and other COVID indirect and direct impact. And they concluded that maybe HIV and the malaria death would be doubled, and tuberculosis also add a lot of the death, and maybe we'll lose the progress in the past of 10 years or 20 years. So even we Global Fund usually dealing with three diseases, but we had to work and combat this COVID because we are the largest multi-lateral financier for global health, and the money is available in country. So we try to be flexible to use those of money for COVID, because a lot of disruption of HIV, TB, malaria, the programs as well. And we have a good experience to fight against infectious diseases. And, mostly testing, tracking and treating, and the human rights issues like discrimination of COVID patients or health workers, and the community-based approach is quite similar. So we could utilize this experience for COVID as well. And we are quite good at strengthening the laboratory and the procurement supply chains. So we made most of our experience and our partners for this COVID one. We have a great partnership at global, regional, and country level, not just only with government, but also international organization, UN organizations, NGO, private sectors, and civil societies. So we, mobilize and leverage the resources for this COVID. So what we have done is, rapid and flexible and at scale support. So we mobilized our own resources and also additional resources of $1 billion US, and we already provided to 106 countries and 14 multi-country grants. So, in this kind of crisis, the rapidness and the swift action is very, very critical. Sometimes UN or international organization and arenas bit kind of slow in motion. We have a lot of meeting and discussion, but we need to move into the action. So this time we use that our grant flexibility, reprogramming or repurposing our money for COVID and combat with COVID within 3 days. So anyway, we need to assure kind of and also need to well manage that financial things. So we need to assure that the financial the management. So we invited that kind of the reprogramming and repurposing from countries, and we had to review and approve process. But we did that review and approval within 3 days. And for COVID-19 response mechanisms, it is kind of new money and new application, but we also reviewed and approved within 10 days. So we supported a variety of NGOs and civil societies to help testing of COVID and treating COVID or isolation at the community level. We supported diagnostics and PPE, personal protective equipment, and the therapeutics, especially oxygens and others. And of course, we need global collaboration solidarities because it is huge programs. So a single, agency could not deal with. So mainly the 9 international organizations and philanthropy, including Gates Foundation, WHO, Global Fund, and etc. Gathered, and we made access to COVID-19 to accelerator we call ACTA. And we made 3 pillars: vaccine, therapeutics, diagnostics. And we tried to connect the 3 by health system connectors. Almost daily meeting initially, and nowadays weekly meetings we have among these main partners, and we discussed. In this kind of global collaboration, we need several steps, but setting target, we set the 2 billion to provide vaccines, 245 million providing new therapeutics, and 500 millions to provide diagnostics by mid 2021 or end 2020. So we usually set target, and we calculated, and we set the target of 38 billion US dollar for this ACTA. But so far we got a pledge around 5 or 6 billion. So still, lacking. So this is Global Health Campus. Nowadays, even physically, we gathered. So Global Fund, Gavi, United, and others are now, staying in this new campus. But of course, now this is closed, and we are now staying and working at home. And this ACTA is not just stimulating R&D, the research and development, but also market shaping, manufacturing, and a very swift procurement and demand generation, and in-country delivery. So as I said, this kind of global solidarity and effort and collaboration needs initially that the goal and target setting, and need to exercise an investment case using the mathematical modeling and scenario setting and cost analysis. And we set the target, and we calculate that the budget in need, and we of course need resource mobilization and implemented monitoring. In this kind of a very urgent situation, we need to do these steps, not step by step, but at the same time, then several steps at the same time. Okay, so far we made a quite good progress. Two new RDT, the rapid diagnostic tests, are developed and approved. And we had a kind of a performance the evaluation, and yeah, a lot of things. And so far we already procured and start distribution 27 million molecular tests and 12 million rapid antigen tests. Yeah, maybe I want to skip this, but we also need training. So we had online training, or yeah, deliver for the 23,000 participants or health workers for this. As you know, we need to protect the health workers because they are really kind of front line workers and fighters for this COVID. But we initially have to protect them by personal protective equipments, and also need to provide good proper training for this. And fortunately, we already distributed this automated PCR testing for TB and malaria. And this, the automated the testing could be used for COVID by developing this small cartridge. Actually, this small cartridge is a bit more expensive than TB and the HIV one, but still they provided $20 US per cartridge. And it is very fast, just only 1 hour. This is PCR test, but just only take 1 hour for showing that result. And the right side is an antigen rapid test. We already procured so many tests, and we have now the 2 tests, just only 15 minutes to show that the result, and it costs just only $5 or less than $5 per test, very cheap. Okay, a vaccine pillar. Most of the people are very much interested in this vaccine pillar. We call, this vaccine pillar, and also COVAX facilities, created by Gavi and also CEPI. CEPI is a coalition for epidemic preparedness and innovation. This CEPI was created in the World Economic Forum several years ago, and it is also a private-public partnership for stimulating R&D and the procurement of new vaccines. And yeah, so this is kind of platform to support R&D and manufacturing and procurement and negotiating pricing. And as you know, as of 12 January, we have 63 vaccine candidates in clinical stage and 173 preclinical stages. And usually quite difficult to find a vaccine, even more than 30 years of research and development. There's no malaria vaccine, there's no HIV vaccine, but surprisingly, this COVID vaccine is almost developed within 1 year. It is really amazing. But this COVAX tried to reduce that risk of this R&D. So they included 9 candidates for this COVAX. And COVAX includes that advanced market commitment. It is kind of innovative financing. We try to collect and mobilize resources, money in advance, and try to utilize those for R&D and all procurement and manufacturing, etc. And finally, they raised at $2 billion for this, and 94 higher income countries, including Japan, other G7 countries, but not US, except the US, joined this COVAX facilities, and supporting 92 low and middle income countries. Now, as you know, the quite effective vaccines are available. Oxford and AstraZeneca, Pfizer, Moderna, and others. But actually, it is not so easy. You know that the effective vaccine developed is not the end of the game. I've been working for the EPI, the expanded the immunization program in Africa and other countries. Even I was working in UNICEF headquarters in New York for this vaccination. But we have now, for example, 97% efficacies of vaccine is measles vaccine. Yeah, and we have been working for measles for several decades, but still we could not eradicate or eliminate, even control this measles. As you know, even in Japan, sometimes you have an outbreak of measles. Very, very difficult to, really kind of eliminate one of the diseases. Okay. And, how to allocate and distribute these vaccines, because, the manufacturing capacity is limited. Who prioritize for shot, and the logistics is also very difficult. One of the vaccine need the cold chain less around the -70 degrees Celsius. Even ordinary the cold chain, the vaccines need the cold chain less than 8 degrees Celsius. So when I was working in Somalia and other African countries, one of my work is the logistics, how to send the vaccine last mile to the very, very remote area. So like you see, in this photo at the right side, this kind of, health worker has to bring this vaccine sometimes several hours in a very, very hot semi-desert zone, and have to give the shot. So, this logistics is very hard. Of course, adverse effects still do not know. Even they evaluated the adverse effect in this clinical trial, but usually we do not know, because sometimes, that after the immunization, we come to know that some of the adverse effect. Of course, vaccine hesitancy is still huge, so some of the countries may turn down this vaccine shot even available more than 40% of the population, or sometimes more than 50%. So a lot of discussion. Many rich countries already or now securing that vaccine by bilateral negotiation with manufacturers. UK has already contract or agreement with manufacturers, several manufacturers, even covering whole population. And Japan, also you are making so much kind of effort for that securing. So I understand, such kind of the countries kind of efforts, because they really need to protect their own national people. But if we leave those kind of effort as it is, poor countries could not get access to this limited number of the vaccines. And if you analyze that kind of allocation, if the vaccines distributed only to high income countries, only 33% of deaths could be averted. But if you allocate these vaccines, limited number of vaccines to all the countries, even including poor countries or low income countries, 61% of death could be averted in the world. And even the rich countries are protected. And if not, that low-income countries' populations are not, protected, this COVID could not be ending, right? Because that pathogen would not respect the border. So this is not a matter of only rich countries, but whole nations. So vaccine allocation, usually the allocation model is very, very difficult. We have also kind of the allocation and investment case. So at the time of allocation, it's very, very hard to developing that allocation model using GNI and, the disease burden and some of the key populations, distribution, etc. But very, very difficult. So now that there are some debates between proportional allocation or fair priority model. So current COVAX, is planning to have a proportional allocation. So initially 3% of populations in all the countries to be provided, the vaccine provided to 3% of population initially. And second phase is, increasing to 20% to high risk groups. So initial protected populations are high, health personnel or elderlies, and going to be kind of high risk. But other, the experts really show that maybe better to give this allocation of vaccines according to the fair priority model, maybe looking at premature death or social economic factors or community spreads. Let's see how, the SAGE group in WHO would provide that the suggestion for this allocation. But anyway, now this is a kind of hot topic, how to allocate the limited number of vaccine. This is a really kind of a public health ethical issues. Okay, so we don't have enough budget for purchasing and distributing this even vaccine. And as you see that diagnostics and the new treatment, if available, also quite difficult to distribute to low-income countries. That is why we are now seeking that variety of other options of innovative financing. Anyway, I want to skip there, but you need to look at variety of innovative financing like loan, buy down, debt swap, and etc. Mainly, we are now discussing with World Bank. Actually, in my division, in the Global Fund, we set up a new department in my division. It is Health Finance Department, because this financing is very critical in this new era of COVID, because all the countries are suffering from their own, budgeting and the financial resources, and we need to, mobilize domestic resources and also innovative way of finding financing. Okay, so where to go? So maybe there are several scenarios for ending epidemics. One is eradication, and the other one elimination, control. Maybe many of you experts know that the difference of these three terms. Eradication, as you know, we need to know that eradicability. So there are some conditions, very clear and also effective diagnostics testing, and also quite evident the symptoms and no reservoir, other than human. So we only succeeded in smallpox eradication, but no others. Many other pathogens are also tried for eradication, like polio, guinea worm, malaria, yellow fever, etc. But it was quite difficult. Of course, now the polio and guinea worm are quite under control, and also going to be elimination, but quite hard. And the elimination, already, we have done so much kind of effort for lymphatic filariasis, leprosy, and etc. But the elimination is also quite difficult. Control is kind of a possible potential one, but we need to look at kind of measures. So we usually, set the kind of target for ending epidemics, and we set a very clear target for HIV, TB, malaria. But looking at target by 2030, it's very big gap between our current trajectory and the real target. So what I want to say is not so easy to ending the one epidemic. And currently there is a very big debate regarding the merits of lockdown. So one, kind of the suggestion from experts group are Great Britain Declaration, they propose that a new strategy to combat COVID, because they said that the lockdown gives us so much, direct and indirect negative effect in short term and long term. So they propose that the minimizing mortality and social harm until reaching herd immunity, but providing the focused protection by protecting high-risk groups and ease restriction on low-risk groups to establish immunity. But other experts groups really kind of against this declaration, and they made a kind of John Snow memorandum. And they said that the lockdowns are initially very necessary to reduce mortality and protect the healthcare, and natural herd immunity would not be happening. And nowadays, a lot of kind of evidence shows that. So there are kind of debates. So what I want to say is there's no kind of perfect answer. And each country, every countries have this kind of debate, even between experts. So it is not only, Japan as exception. You also have a variety of debate, I understand. But you don't have so many experts. So there is not so maybe big debates. But even, Sweden, UK, US, there are a lot of kind of this kind of debates. So, what kind of efforts to end COVID-19? Important one is compliance, not just only measures. I've observed that in Japan, there is big debates or kind of criticisms on government measures. But important one is not measure or strictness of political measures or policy, but more important one is compliance or responsiveness of the people with effective measures. So most of the countries observing second or third wave of epidemic are the countries poor compliance, I can say. So my friends in France, UK, and others, they said, people are, going just very much easy and, wearing, without wearing masks, they are really kind of, making noise and we had a big Christmas party and others. Could you imagine European countries kind of ease that restriction on the day of Christmas Eve or Eve? So even in Switzerland, until the 1 a.m. of midnight of the first year, you know, they had a party inside or outside of the houses. So they have to be a bit kind of generous sometimes because the people could not the stay home at home, and sometimes they really kind of explode because of that limiting their kind of the mobility. So, but this compliance is very, very, very hard. That's why maybe you need a kind of differentiated approach, or some countries they call the tiered approach. So between high risks and low risks, and hammer and dance kind of approach, also very much needed. But maybe kind of lockdown as a last resort. And also, of course, in the treatment and quality of care is very, very critical to increase the survival rate. And but I want to emphasize that COVID-19 is not only pathogen to affect people. There are a variety of more pathogens, diseases, and not only just communicable diseases, but also non-communicable diseases, and even mental, the stress and the illnesses. So, of course, important to end this COVID-19, but we need a more kind of comprehensive wave of approaches, how to just deal with variety of, the diseases, and how to also, make a big, good balance between this, social and, economic issues, and also public health issues. That is why, we need to look at kind of a data and evidence, and we can utilize, the additional new evidence for, better integration and an innovative kind of way of working. Okay, I want to stop there, and thank you very much for listening, and welcome your question or comments.
Thank you very much, Dr. Kunii. It was very comprehensive, very in-depth in regarding this COVID-19 and also other pathogen effort that the global funding is trying to tackle. I'm sorry for some technical difficulty in the very beginning, so that some of the participants could not attend. So I will make this video available after a couple of days so that you can all watch the entire presentation of Dr. Kunii. So don't worry, I will let everybody know the link. And also, because you missed the first instruction, so if you have any questions, please send through this Q&A column on the bottom of the screen so that we can pick each one of the questions now. Because we have a time constraint, is it okay to extend a little bit of time, Dr. Kunii? Okay.
Yes.
So, okay, so let's take one first question here from Mayu. She says, I would really appreciate it if I could ask question around 1, local manufacturing sub-Saharan Africa, 2, shortage of PPE in SSA, and 3rd, potential collaboration with IFC upstream team. Sure.
Sorry,
she wants to elaborate. Okay.
Sorry, I couldn't listen to a second question. I understand the first question.
Second question is shortage of PPE and SSA. Yeah.
Okay, so can I respond? Yeah, nowadays many countries now start manufacturing PPE, especially the masks and some of the the clothes. But as you know, especially masks, we need quality control, because as you see that the effectiveness, efficacy of the masks are quite different, based on that the materials and structure. So we really need to, have a kind of standardization or kind of quality assurance. But they are kind of increasing the kind of locations and manufacturers of this manufacturing PPE in sub-Saharan Africa. And some of the private sectors also supporting that kind of things. Okay, any other question?
Okay.
And I can say, the ventilators, artificial ventilators, if you buy a nice one, it costs a lot, huge amount of money, more than 20,000 US dollar. But nowadays, 3D printing or kind of open source kind of, the support for manufacturing the ventilators, very, very simple ventilators. They are also used in African countries as well. I just want to add.
Okay. So Maya, do you want to elaborate a little bit more?
Thank you so much. Yeah, I think my point shortage of PPP is like, Nigerian doctors left Nigeria for UK due to the shortage of PPE in Nigeria. So, this issue will worsen the shortage of medical staff in African countries in the, long-term run. So, yeah, from that perspective, I asked the second point. And the first point is local manufacturing. COVID-19 reveals the securities of countries like local pharmaceutical manufacturing. However, there are some issues around the local manufacturing in sub-Saharan Africa. For instance, in anti-retroviral space, top API suppliers control the market. And without the relationship with them, no one can play in the space. So I understand the Global Fund started to offer some incentives for local manufacturers a couple of years ago. So could you elaborate the local manufacturing incentives, how those will, support local manufacturing, both API production model and mixed import model? That's the local manufacturing point. And the last point, potential collaboration with the ISC. ISC has recently established an upstream unit which develop market creation type project and bankable, investment projects. And the current project include COVID-19 testing, mobile clinic expansion. So I'd like to understand, whether is it, there's opportunity to, discuss further with the ISC upstream, between the Global Fund and the ISC upstream team. Thank you.
Okay. Yeah, thank you very much. Maybe you can send me a kind of a personal email, and maybe you can set the kind of meeting for that purpose in the second one. And yeah, actually, the local manufacturing, we're not supporting financially, but because there are many other private sectors and agencies who are kind of interested to support, but not the Global Fund directly. But we feel it is quite important for the countries in countries, especially the middle income countries, to increase their capacity of local manufacturing. But before that, actually, that the quality assurance is more important for us, Global Fund especially, because ART and the artemisinin combination therapy and etc. Because we have a lot of the resistance to those medicines. That is why we really need to control that resistance. So counterfeit drugs or low quality medicine will be really kind of troublesome. But nowadays, there are several. For example, Nigeria is a really kind of a big country and quite high standard of manufacturers or that the technologies are available there. So maybe it might be possible for Nigeria or South Africa or maybe Kenya to set some of the manufacturing of API or other kind of substance. Maybe I want to stop here, and maybe we can discuss later much more kind of detail. Any other question?
Any other question? You can send us a question through this Q&A column if you have it. Otherwise, I have a question to Dr. Kunii. As you have laid out, the cooperative effort by various actors, organizations, because U.S. is absent from this, COVAX facility, and maybe not have been so present for the past years because of Mr. Trump's attitude. And I hope that the US will be back, if Mr. Biden comes into power, but we don't see clear leadership in this global community. And with that situation, who will be leading this, all the multilateral effort? Well, without having any clear leader, are we able to still continue this, multilateral effort successfully? Appreciate your comments.
Thank you very much. It's quite difficult to say the leadership, because this is kind of partnership, and there are a variety of steps and processes we have to make in this kind of global collaboration. So for example, setting a kind of standard or the pre-qualification kind of a review and etc. We really have to involve WHO. So WHO is kind of leaders of technical kind of guidance or norm setting, okay? And facilitating that R&D, stimulating R&D would be a private sectors actually. Maybe US could be also supporting financially and technically, but even Germany, France, and UK also have a quite good manufacturers and also expert on that one. So they can work together for R&D. And procurement may be better for UNICEF and the WFP, the Global Fund work together for rapid procurement and distribution to the last mile. And the training, again, the WHO needs to provide guidance for training. So, variety of, steps we need. And of course, World Bank also needs to be stepping in for innovative financing, etc. So actually, there are a lot of, roles and functions and the leadership and management needed in this kind of a big one. But I observed that this kind of innovative collaboration is very much needed. But finally, each agency's capability and capacities are very, very critical. Because if each of the agencies have a very limited capacity and a limited capability, maybe it is quite difficult to drive kind of big movement and also achieving the target. That is why, for example, Global Fund, we make most of our own resources for ACTA, and finally we need to contribute, our capability to this ACTA. So maybe each agencies needs to bring their own the added value and also comparative advantage to this kind of organization. US's role would be very important technically and financially. They have a quite good expertise in CDC, USAID, PEPFAR, etc. But because of this, the WHO issues, they haven't attended many of the technical kind of meeting in the past, especially the WHO related one. But I hope they will be back soon. And we are now discussing with new administration for better financing for this COVID one.
Okay, thank you. So we don't have more question. Is Dr. Kurokawa, would you like to give us your view, or they ask questions to Dr. Kunii? Dr. Kurokawa? Dr. Kurokawa? May not be here. There's one more question actually coming through. Previously, the person who sent us a question, she said that, as you said, there are all nations around the world having difficulty just dealing with domestic problem already, and they don't have really capacity to look for other nations. So is there any things that individual citizens can do in order to help this collaborative effort to tackle this COVID-19?
Yeah, of course, depending on that the individual's interest and also capacity, expertise, etc. But you can see this time that civic tech is quite important, and some of the civil societies, especially with the expertise of ICT, supported the variety of things like designing 3D printing for the artificial these ventilators, and also supporting that infographics, analysis and synthesis, and the visualization of data. So Johns Hopkins and other mass media, even some of the individuals contributed making that kind of a visualization of infographics and etc. And Code for Japan, that kind of society is also supporting that generating that good infographics for Japan's COVID situation. And some of the expertise also provided the data and information of mutation, so that yeah, there is some platform to provide all kind of a mutation, so that they can show that the change of the genetic codes to and share those information with other experts. So there are a variety of things you can do, and of course that writing report and also scientific paper also gives a good contribution to other experts and other people for generating that evidence and experience sharing. And also you can give donation. I'm also kind of supporting some of the donation and also providing that to medical facilities suffering from this COVID and others. So maybe even your small donation would be helping to others who are suffering from job loss and others.
Dr. Kunii-san.
Hi. Yes.
Thank you very much for your very clearly described COVID-1 thing. My argument is COVID-1, unfortunately or fortunately, become a pandemic, so that in this connected world we can learn and share a response of each country and just navigate so that we could be really sharing what we can do. And the second one is, I think even there's a sort of vaccine have been under sort of production when it's available. And this is completely different from HIV that type, like vaccine for, let's say, malaria and others, because all the rich countries are affected by COVID too. So I'm sure they're going to sort of prioritize their vaccine available to their own people. So how to sort of share this limited amount of vaccine sort of to the world, particularly sort of low-income countries? That's my sort of inquiry to be. I'd like to hear what you think.
Sorry, can I clarify the question? First one is a kind of a contribution from each countries. The second one is a kind of vaccine production or distribution to low-income countries.
Because availability of vaccine will be limited in earlier phase anyway.
Yeah.
And this is different from other, let's say, malaria and others, and also which countries also people are affected. So how to prioritize and share this vaccine? That's the question.
Okay, vaccine of COVID, right? COVID vaccine.
Yes.
Okay.
Right.
Yeah, thank you very much. First question, contribution. Variety of contribution each country can do. Of course, based on their own capacity and whatever. For example, China, maybe there is a lot of kind of argument there, but they provided the kind of the information initially, that the code of all genetic codes, and also they contribute a lot about the evidence. A lot of epidemiological study among the patients, and other the data are also shared in the world. And other countries, also G8 countries, also provide a lot of such kind of data and information. So to kind of such kind of information sharing and also kind of discussion would be very, very critical. And of course, some of the the packaging of non-pharmaceutical interventions, and that effect also would be also quite important for others. And of course, R&D, that the developing new medicines, diagnostics, and vaccines are also very, very important for the global contribution, of course. And the monetary contribution, as I said, also quite critical, especially from rich countries to low-income countries to support. Technical support also, of course, that especially low-income countries have quite the lack of such kind of technology and also technical kind of knowledge to do. So yeah, a lot of contribution could be done to each other. I also feel the importance of a regional collaboration or regional kind of a hub, like this time European CDC and African CDC contribute a lot, because each country are kind of suffering and could not go beyond, but regional office or agencies could coordinate among those. And the region is quite good because situation is quite different from country to country, but quite similar in the region. So EU, that the European CDC really helped a lot for information sharing, etc. there, and African CDCs, yes. And I kind of propose, in Eastern Asia, also maybe Japan, Korea, China, Taiwan. Nowadays, Thailand also has a quite good, public health knowledge and etc. So maybe you can have some good networking among that expertise and the others in Eastern Europe, Eastern Asia, so that you can also kind of analyze that some of the success and the lessons of this COVID, and maybe utilize those for the future pandemic. Second question, yeah, I already mentioned in my slides, variety of kind of allocation methodologies. As I said, that current limited the vaccine would be shared to all the countries who are belonging to COVAX. That initially the first phase is the 3% of the population okay, population, mainly targeting the frontline health workers and maybe elderly, and gradually, just increasing that priority. That is why each country has to set the priority for this immunization. And yeah, but this kind of proportional allocation is now under kind of debate, because it is a Lancet or BMJ just argued better not to give this allocation proportionally, but more the need that consideration of premature death and the disease burden and ability to pay, the GNI. Actually, we Global Fund, we also have an allocation methodology based on two principles. One is ability to pay. So the countries which cannot pay get more money. And other one is disease burden. The bigger burden countries get more allocation. So, and of course, we need some adjustment by key populations or kind of variety of the factors to be considered or adjusted, but mainly we use two kind of indicators. So maybe in this COVID one, I also quite agree. Personally, I agree that premature death and the disease burden of COVID and also ability to pay, these three are quite important for consideration. But of course, this is and COVAX, and I'm not involved in this kind of allocation methodology, so I just want to leave it there.
Thank you very much. I think we went over time, and I just want to thank Dr. Kunii and everybody who participated today. I very much thank you for your time, and we'll make this video available as soon as possible. And I hope that you will join for the next session as well. We are planning a next session on January 26th, inviting Dr. Sanjaya from Australia. He's going to tell us about Australian approach, how they deal with the COVID-19. So I will send the information around, and thank you very much for participation. Thank you very much, Dr. Kunii, for your time. Appreciate it.
Thank you.